Hello, my name is Eric, and welcome to Strong Medicine. For those of you who are new here, I'm a hospitalist and a professor at Stanford School of Medicine. Today, I'm going to talk about a particularly challenging topic: the complex relationship between individuals with chronic physical illness, those who honestly but mistakenly believe they have chronic physical illness, those who are deliberately faking chronic physical illness, and the medical professionals who struggle to sort out who is who. This topic has been discussed on social media many times before, but this will be a deeper dive than you've seen, and one from a physician who treats patients with complex illness that sometimes lacks a clear physical explanation. I was inspired to explore this topic after coming across a Reddit post on the medicine subreddit this summer. It was written by user Anonymous1011 and entitled, "Goodbye Medicine, I have loved every second of it."
I've worked in medicine for 20 years, first as an emergency medicine doctor, and now for the past 10 years, an anesthetist. I have been diagnosed with stage 4 stomach and pancreatic cancer. I know my odds, and I'm comfortable with them. I haven't worked for 4 months, but I contacted my boss at the hospital, and I am doing one final shift in 3 days. Routine appendectomy on an amazing patient who has been in and out of the OR for years, with my husband as the lead surgeon, my favorite scrub nurse, and my amazing intern, surrounded by people I love and doing a job I have loved for the past 2 decades. Thank you to medicine for giving me the best years of my life. So while I don my cap for the last and final time and count with my patient back from 10, I'll think about everyone whose lives I have improved and everyone who has improved my life. Goodbye. It's been nice knowing you. Thanks for the ups and downs, the memories, and meeting the best people.
The post was liked over 2,000 times, which for this subreddit is an extreme outlier. At the time, it was the third most upvoted post in the preceding 12 months. It received dozens of positive and uplifting responses, ranging from the brief and to the point to the more verbose and even poetic. But a few people were, shall we say, a little more skeptical of the story. First, there is the fact that the user has both stage 4 stomach and pancreatic cancer at the same time. Is she somewhat imprecisely saying that her stomach cancer metastasized to the pancreas or vice versa, neither of which is common, or is she meaning literally what she's typed, that she has both metastatic cancer originating from the stomach and from the pancreas simultaneously? That would be even more rare, but theoretically possible. In the next line, though, the story completely falls apart. She hasn't worked for 4 months due to terminal illness, but she's being allowed to scrub for one final case? In other posts, she has stated that she was still hospitalized as recently as the previous day. Aside from this coming back for one final case feeling like an overused trope from a made-for-TV movie, a hospital would not let her do this. When one takes a closer look at the user's post history, her story becomes even more unbelievable. She had created an entire persona, albeit multiple different versions, of being a successful married Australian anesthesiologist, married to a surgeon who's had various forms of serious illness in herself and her family. Here she is on r/cancer saying that she has APML, a form of leukemia, stage 3 or 4, with lumps on her pancreas and stomach. None of this sounds like a physician. APML is an uncommonly used acronym. APL is much more conventional. It's not staged on the 1 to 4 scale like solid tumors, and to cause solid tumor-like masses on multiple organs would also be profoundly rare. 6 months ago, she was posting on r/CFS for chronic fatigue syndrome that she had POTS, type 1 diabetes, hypermobile Ehlers-Danlos syndrome, and mast cell activation syndrome. Meanwhile, over on r/addiction, she's also apparently an MDMA addict, referring to ecstasy, a claim which later led to a sad attempt to do an AMA on what it was like being a functional addict while also being a mom. Her 5-year-old daughter also apparently had leukemia, while another child has diabetes, gastroparesis, and needs a G-tube. There are other posts portraying the fact that she has limited medical knowledge despite supposedly being a physician. So in short, user Anonymous1011 is a fiction. When skepticism was first voiced on her post, she stopped all replies, and within a day, the year-old account with hundreds of posts and thousands of karma was deleted entirely. So why would the user behind Anonymous1011 do this? Why would a person pretend to be a doctor with terminal cancer, or any of the other diseases she claimed to have? And how did thousands of medical professionals fall for it? Welcome to the deep, dark rabbit hole of illness fakers. People who fake having a serious illness in order to meet some form of psychological need, or in some cases to commit fraud. I've spent the last few months not just reading the literature on this topic, but also immersing myself in the online discussion about illness fakers and alleged false accusation of illness fakery. I've seen a common trend. Many people, patients, medical professionals, and layperson bystanders alike, have an overly simplistic view on this issue. Many people imply there are two buckets of patients, one for those with so-called real disease, and one for so-called fake disease. A quick note about this Venn diagram that I'll be coming back to a few times. It is only meant to show the relationship between disease categories. The areas enclosed by those shapes do not represent the relative prevalences of those categories. A slightly more nuanced take would be to subdivide real disease into the categories of organic versus functional, in which organic diseases are those accompanied by measurable and objective biologic changes in the body, whereas functional diseases are characterized by subjective symptoms only. For example, if we consider two diseases that can cause abdominal discomfort and chronic diarrhea, celiac disease is an organic disease since there are diagnostic blood tests and characteristic changes that can be seen on biopsies of the intestine, whereas irritable bowel syndrome, which is still very much a real disease, currently has no objective diagnostic tests. Diagnosis is based solely on symptomatology. Unfortunately, this predominantly dichotomous model falls very short of representing reality. Because of its oversimplicity, laypersons misunderstand what's going on with individuals they encounter online, and medical professionals misunderstand individual patients they encounter in real life. This results in misdiagnosis, false accusations, distrust of physicians, distrust of patients, and a failure to get proper treatment for the many people who are caught up under this giant umbrella of chronic illness. We need to do better, but to do better we need more nuanced categorization and precise nomenclature. I'm going to spend some time incrementally revising this model until it becomes something useful to truly understand people's illness and their experience. First, when I was in medical school, we were taught a more complex model of these so-called fake diseases that separated them into three categories. One for somatoform disorders, in which the patient does not have a physical illness but honestly believes they do. One for factitious disorder, also known as Munchausen syndrome, in which the patient deliberately fakes illness for unconscious or psychological benefit. And one for malingering, in which the patient deliberately fakes illness for money, to obtain housing, or to avoid work, prison, or military service. For example, anyone who has seen my videos on Robin Nacita, the woman who unsuccessfully attempted to avoid prison by faking a brain tumor, that was a classic, if not somewhat involved case of malingering. But even this model, while closer to the truth, still falls quite a bit short. For one thing, there is another critical category in the real disease bucket, real disease that is not yet diagnosed, either because the individual has not yet had the appropriate tests, not yet seen a sufficiently knowledgeable doctor, or because the disease has literally not been discovered or described yet. You might think, hey, it's 2024, how many more diseases could still be out there undiscovered? Well, the disease ME/CFS, which is the prototypical example of a chronic functional disorder that affects millions of people globally, did not receive a proper definition until the 1980s, and that definition is still evolving. Alpha-Gal syndrome, a condition which I covered on this channel a few months ago as an underappreciated disease, that wasn't discovered until 2008. I very strongly believe that there are more diseases left to discover, and collectively they are common enough that I have probably seen some patients with one. Another reason this model falls short, the implication that everything on the right is fake. Just because somatoform and fictitious disorders are psychiatric in nature doesn't make them not real. The only true fake illness is malingering, which needs to be separated out entirely. And we can further explore what remains, now relabeled psychiatric disease, and subdivide them yet further. For example, somatoform disorders, and the specific terminology here is constantly changing, include somatic symptom disorder, in which the patient is excessively focused on one or more particular symptoms they are experiencing. They're not from a diagnosable physical illness. Functional neurologic disorder, formerly known as conversion disorder, in which the patient reports an alteration in voluntary movement or sensory function without any demonstrable anatomic basis. A recent example of this was the phenomenon of neurologic tics associated with TikTok videos during the period of remote schooling and social isolation in the first 2 years of the COVID pandemic, which we will come back to. And illness anxiety disorder, commonly known as hypochondriasis, in which the patient has an anxious preoccupation with having or acquiring a serious illness, while actual physical symptoms are either absent or are relatively mild. Within factitious disorder, there are also subtypes. There can be complete falsification of all symptoms, falsification or exaggeration of some but not all symptoms. Partial falsification might also include false attribution of symptoms, in which the true cause of real symptoms and medical complications is known to the patient, but the patient lies about them. For example, if a patient was to claim that their hair loss was from chemotherapy for cancer rather than from a true cause of alopecia. And then there is trolling, in which a patient pretends to have an illness within an online forum or other virtual community for the primary purpose of taunting or confusing people in that community. In this framework, I am not including factitious disorder imposed on another, also known as Munchausen by proxy, in which a person deliberately makes another ill in order to get perceived psychological benefit from serving as their caregiver or advocate. At this point, we need to take a small diversion from the model to discuss a similar sounding term, Munchausen by internet. Within this space, here on social media, talking about people faking illness, Munchausen by internet is one of, if not the most commonly used terms you'll come across. People with this disorder are pejoratively referred to as munchies. Yet, these terms are virtually never used by physicians. I've been asking around at the hospital and the medical school, and despite countless mentions of it on Twitter, Instagram, Reddit, and YouTube, very few physicians and med students that I've talked with are familiar with Munchausen by internet. First described and defined in 2000, Munchausen by internet, or MBI, refers to the situation in which an individual fakes an illness, but the deception occurs predominantly or entirely online. Instead of doctors' offices and hospital ERs, their illness plays out on social media. This provides individuals with factitious disorder two huge benefits. First, they have enormous reach from which to fill whatever emotional need they have. So instead of getting sympathy and support from a dozen close family and friends, they can have thousands of followers monitoring the ups and downs of their reported illness. Second, it's much easier to fake an illness online. You don't have to memorize complex medical presentations when you can just read from a script. Also, for individuals with conventional fictitious disorder, sometimes they will need to go to extreme and dangerous lengths to induce actual pathologic changes in their body that mimic chronic diseases in order to fool medical professionals in real life. I'm not going to list the specific ways this can be done as to not give anyone any ideas, but some of what can be done can literally be fatal. Now, when someone is posting status updates on their chronic illness on social media, they will inevitably include pictures of them in the hospital. But without commentary from the medical team, who knows whether the actual reason for hospitalization remotely resembles what they claim it's for. As it may have already occurred to you, Anonymous 1011, the terminally ill Australian anesthesiologist with 3 different cancers, POTS, EDS, gastroparesis, and an addiction to ecstasy, that user is an example of Munchausen by internet, though perhaps not a classic example, as most MBI individuals are not anonymous and frequently show their real face on camera. Thus, anonymous might also be a troll. MBI and trolling, they're not mutually exclusive, as you can see when we return to the model. You might assume that MBI is just a subtype of Munchausen syndrome, but in practice the term is used online in a less precise way, and, in my opinion, beyond its original intent. Its common online usage also encompasses some cases of malingering for fraudulent crowdfunding, as well as cases that very well may be a functional neurologic disorder. Yet another new term of relevance, mass social media-induced illness, which refers to the contagion-like spread of fake illness via social networks such as the previously mentioned TikTok tics. Two conditions that have become infamous for spreading like this are the tics and dissociative identity disorder. Now, it may sound hard to believe that such an effect could be unconscious on the part of the patient, and you might think that such cases were always deliberate. However, there is historical precedent for this, a well-documented phenomenon called mass psychogenic illness. For example, the dancing mania that affected thousands of people in Europe between the 14th and 17th centuries, in which large groups spontaneously began dancing erratically and seemingly uncontrollably until they collapsed from exhaustion and sometimes died. A much more contemporary example of mass psychogenic illness occurred in New York State in 2011. Over a dozen children enrolled at the same school developed a nearly identical tic-like illness over the span of 4 months. After extensive medical and environmental testing, it was determined that one child had Tourette's syndrome and all of the others had conversion disorder. An interesting observation made by the primary neurologist investigating the cases was that the more an individual child was featured in the media about the situation, the worse the child's symptoms remained, whereas those who were not in the media tended to get better, suggesting that it's not just social media, traditional media can also contribute to the phenomenon. But despite all of what I've said so far, reality is still yet more complicated than this diagram because nearly everything overlaps. Having factitious disorder, a functional neurologic disorder, and some form of true chronic physical illness, all that can coexist in the same person at the same time. And they can also evolve over time. For example, a person can start out with chronic physical illness, and then driven by psychological benefit their illness brought them, it can later develop into factitious disorder. Or a person who starts off with factitious disorder can, over time, eventually start truly believing that they have the symptoms or the disease that they were initially just pretending to have. A person could be diagnosed by a good physician with a serious disease that has objective observable findings like various forms of dysautonomia, but then that person could incorrectly convince themselves based on interactions in online communities that they also have less objective conditions like Ehlers-Danlos syndrome or mast cell activation syndrome. And maybe they are so convinced that they deliberately misrepresent some of their symptoms to gain additional diagnoses, which they honestly believe they have. Where does that person fall on the Venn diagram? To address the problem in which some patients are not easily classifiable, there's a second, completely different model that can be used to understand them. We can consider 3 independent domains in which a patient's state can be scored. One is the presence of physical illness, a second is the belief in physical illness, and the third is the presence of deception. So if we had a patient with endometriosis who believes that they have the disease, who has clear objective evidence of it, and who exhibits no exaggeration or falsification of symptoms in any way, this is what their indices would look like. And here is what it would look like if we had a patient with pure factitious disorder in which they are knowingly faking an illness for psychological gain without any actual or belief in chronic illness. Those are straightforward examples. But what would it mean to have a patient whose indices look like this? Here we have a patient with some degree of chronic illness who believes they have more chronic illness than they really do, but on top of that honest but partially mistaken belief, they are also falsifying some symptoms to either make an actual diagnosis seem more severe or to give them an additional diagnosis that they don't actually think they have. This could be a patient who meets criteria for hypermobile Ehlers-Danlos syndrome, who has been given that diagnosis by a reputable physician, but who also mistakenly believes they have mast cell activation syndrome, on top of knowingly faking gastroparesis symptoms so they can get a feeding tube because an online friend told them that it helps generate more sympathy from friends and family. To be clear, this model is not very practical because it lacks labels and any standardization. Thus, it cannot be used to easily communicate information to other medical professionals. However, I still think it's an interesting alternative to conceptualizing the intersection between chronic physical illness and these forms of psychiatric disease. Overall, though, it is really complicated, which finally gets us to the core question. Can medical professionals accurately sort out who is who? Who has physical illness versus psychiatric illness versus both versus neither? The short answer is that sometimes it can be easy, but it is often really hard. This channel's primary audience is medical professionals and those in training. And for those of you in these groups, I want to give some guidance on this question. However, some tiny percentage of viewers here suffer from factitious disorder themselves, so I don't want to provide too much of a roadmap on how to trick doctors into believing in fictional illness. But I can give some general ideas because much of this is already openly discussed online. The first indication that a person's physical illness may be predominantly psychiatric is that the illness does not seem medically plausible or aspects of it sound bizarre. For example, Reddit user Anonymous1011 claimed that she had 3 different relatively uncommon cancers developed simultaneously. That's not technically impossible, but it would be a profoundly rare event that should already by itself raise modest suspicion. But a big caveat is that some diseases do present atypically, and the more rare the disease, the less well established that disease's typical presentation will be. Second, the medical history as provided by the patient is contradictory. For example, claiming one day to have lost 10 pounds and the next day to have lost 30 pounds in the same time period. Or completely different dates of certain procedures are given during different interviews or in different social media posts. A big caveat here is that people can have surprisingly poor memory about their health, and if using the medical chart for comparison to identify inconsistencies, the medical chart itself can be wrong. An unusually high sensitivity to medication side effects, keeping in mind that there are some individuals whose immune systems are unusually prone to allergic reactions. I myself have seen a patient with documented anaphylaxis to 7 completely different classes of medication. If the likelihood of each anaphylactic response was independent of the others, this would not have been observed in the history of humanity. However, the greater the number of intolerable side effects to medications a patient has, particularly non-allergic reactions, the more one should suspect a psychiatric component. Next, the patient has multiple events of near-fatal bouts of illness, alternating with miraculous recoveries. Now, while I personally don't believe in miracles per se, I do believe in the rare occurrence of statistically improbable events. So dramatic recovery from near death is fantastic news. 2 dramatic recoveries from near death may just be incredible luck, but 3, 4, 5 dramatic recoveries start incrementally becoming less believable. A tendency to attribute normal physical sensations to medical illnesses. Healthy people get occasional aches and pains. Sometimes they feel their heart skip a beat. Maybe one day they have a bit of constipation, and then a few weeks later they have a relatively loose bowel movement. Not every transient symptom is indicative of an underlying problem that needs to be diagnosed and treated. Yet the boundary of when a physical sensation is severe enough, frequent enough, or lasts long enough to be indicative of a problem is kind of fuzzy. There is an unusual amount of non-illness related drama in their life, although this has to take into consideration that individuals with chronic illness often have greater than average work, financial, housing, and relationship stressors. And last, and surprising to people who have not encountered factitious disorder before, individuals may sometimes have a nonchalant reaction to a medical complication or crisis that would normally lead to great anxiety. But again, individuals with chronic physical illness often have had many diagnostic tests and hospitalizations, and being told by an ER doc that they needed brain MRI to rule out a stroke or a chest CT to rule out a pulmonary embolism is something that they may be relatively used to. So in short, all of these indicators that a physical illness may actually be psychiatric, including factitious disorder, they all have caveats. None of them are a smoking gun for fake illness. There is one exception, and that is malingering. When a patient has clear financial or other real-world gain from the illness, that's a red flag. Like going back to the Robin Niceta case, the woman who happened to develop a glioblastoma after she had lost a $3 million lawsuit and was facing multiple years in prison. That was a pretty big indicator that something was amiss in that particular situation. Once a medical doctor has identified someone as having a psychiatric illness or malingering as a probable cause of physical symptoms, then what? In short, it depends. On one end of the spectrum are people who are unambiguously malingering to avoid prison. When it was clear to me that Niceta had photoshopped a brain tumor into her MRI scan, I felt obligated to pass that information on to the prosecutor. But I wasn't Niceta's doctor. I never met the woman. I only had access to her scan because her mother gave it to a news reporter who posted it online. What could I have done or should have done if I was her doctor? Now, if I knew for a fact that my own patient was faking illness to avoid prison, I'm not a lawyer, but I think it's safe to say the correct course of action would be to consult with my hospital's legal team before doing anything. In the United States, medical professionals cannot volunteer protected health information to law enforcement without a court order unless a person's safety is in imminent jeopardy, like if it's a psychotic person telling their psychiatrist they're going to kill a specific person. But most situations are less clear. For example, I've probably encountered 50 patients over 20 years who I believed to likely exist on the somatoform factitious disorder spectrum, in which at least part of their reportedly physical illness had a psychiatric explanation. But in only a few cases was I sure enough to label it as such when talking to the patient. There always remains the possibility of undiagnosed physical disease, and as I mentioned, I'm sure that I've encountered patients whose enigmatic presentations are from diseases that have not yet been discovered and formally described. But once a presentation is labeled as psychiatric, literally no physician will ever explore a physical explanation for the symptoms again. So you need to be positive that everything else has been thoroughly ruled out. Fascinatingly, among my patients who've been given a diagnosis of functional neurologic disorder, always after concurrence with multiple neurologists, all of them have actually been understanding and appreciative. Beforehand, I would have guessed that they would be angry and demanding third and fourth opinions and not accept our conclusion. But after the condition was explained and they were reassured that no one was accusing them of deliberately faking their symptoms, they all seemed accepting of it and interested in treatment. Finally, the patients who I've suspected had factitious disorder, these are the hardest. Calling out factitious disorder necessarily means you are accusing a patient of lying, and if you're wrong, that is profoundly traumatizing and invalidating to the patient. And once that gets entered into the chart, no one will take that person's symptoms seriously again, either their current symptoms or any new symptoms in the future. So the bar for a medical professional to accuse their patient of factitious disorder is extremely high. While I have once reported the suspicion of factitious disorder by proxy, that is, a family member making my patient sick on purpose, I have never accused a patient of mine of personal factitious disorder. I would need to literally see them deliberately induced illness in real time to make that accusation, and I've never seen that. Excluding people who are malingering and the extremely rare case of catching someone with factitious disorder in the act of inducing illness, the approach to treating everyone else under this extremely general umbrella of chronic functional-like or undiagnosed illness with psychiatric overtones is similar. First, the clinician should provide reassurance to the patient that their symptoms are real, that they want to partner with the patient to investigate the symptoms, and to get the patient feeling better. As a hospitalist, if I'm seeing someone in the hospital with this general phenotype, I emphasize that my primary role is to rule out life-threatening causes of their symptoms and then get them on the path to close outpatient follow-up with a primary care clinician who they trust. And I am upfront at the beginning that we may not figure out a specific diagnosis during that particular hospitalization, but an eventual diagnosis may still be forthcoming in the outpatient setting. Along those lines, these patients should have regular primary care visits, more regularly than most patients. And those visits should be scheduled at specific intervals rather than only being dependent on the worsening or development of new symptoms. If not obvious, the symptoms of potential physical illness must be investigated to the extent medically indicated, and for those patients who are unusually concerned about a symptom or a specific disease, the clinician should consider going just a bit further. Why go further than what's indicated? Well, one could be wrong about what is or isn't indicated. It also provides some additional reassurance to the patient, and it's unfortunate this needs to be a consideration, but it does provide some protection from legal liability. What going just a little bit further looks like will, of course, depend on the situation and the presentation. The bar for sending off an extra blood test or two is low, while the bar for a radiographic study is a bit higher, and the bar for something invasive like endoscopy or biopsy is much higher. In my opinion, clinicians should also err on the side of referring for a subspecialty consultation, even if they don't think it's strictly necessary, particularly if the patient's concerns are outside one's usual scope of practice. But it should not lead into an endless series of consultation after consultation with a third, fourth, or fifth opinion until one specialist finally gives the patient the answer that they wanted to hear all along. There are quack doctors out there in every specialty who are happy to give patients an unconventional and inaccurate diagnosis if it means continued business for them. For the sake of the patient's health and their wallet, clinicians should avoid that. Plus, in general, for patients whose physical symptoms are being driven by psychiatric disease, testing and referrals that are well beyond what's indicated usually don't provide enduring reassurance. If anything, excessive testing and referrals may strengthen the patient's belief in the presence of physical illness, even if every test result is normal. And for patients with factitious disorder, more testing and more referrals provides the patient more opportunity to seriously injure themselves. Even if no physical illness is suspected at first, every new symptom should be investigated as you would for any other patient. For one thing, with a physical disease that was initially mischaracterized as psychiatric, the development of a new symptom provides an opportunity to identify the missed diagnosis. For another, just because a patient has experienced somatization doesn't mean they can't develop a completely unrelated physical illness later. If the patient is willing, enlist family into the discussion around the diagnosis and treatment. For patients with prominent somatization, families can be very helpful if the potential psychiatric component is introduced into the conversation early. But if it's not, families, particularly of patients of teenage and 20-something-year-old patients, can reinforce the false beliefs in a physical illness. They honestly are trying to advocate for the loved one, but sometimes the advocacy perpetuates the cycle of excessive testing and improperly directed treatment. Parent and child together can develop a shared delusional disorder about the presence or severity of a particular diagnosis that can be impossible for the physician to overcome later. Any other psychiatric comorbidities, such as depression, anxiety, and substance abuse, should be treated. Last, and this is not necessary for all patients, but if physical illness has been definitively ruled out as a primary driver of a person's symptoms, and reassurance and education are insufficient to relieve the patient's discomfort and distress, referral to a mental health specialist should be considered. If taking this step, the clinician must reassure the patient that they still believe the symptoms are real. The patient should not be left with the impression that doctors are saying, "It's all in my head." And, I broach the topic of psychiatric referral with patients by discussing how chronic illness of any kind can impact mood, energy, and sleep, and that a mental health professional can help with how someone is feeling, irrespective of what the primary diagnosis is. which is true. A mental health professional can then help determine whether the patient meets formal diagnostic criteria for somatic symptom disorder or illness anxiety disorder. They can help treat the other aforementioned psychiatric comorbidities, and through psychotherapy, can help patients develop coping strategies to deal with their symptoms and potentially even cure them of their somatization. As long as the idea of a referral is brought up in a respectful and validating way, unusual resistance to seeing a mental health specialist is a potential warning sign that the patient may not actually want to get better. In other words, patients who have excessive belief in illness tend to accept mental health referrals that are introduced respectfully, whereas patients who exhibit deception tend to refuse them, as a general rule. In summary, the intersection between chronic physical illness, psychiatric disease, and malingering is complex. Sometimes it's easy to spot who falls into which category, but it's often not. And patients who live and interact in this general space often defy clear categorization altogether. We as medical professionals can risk serious mistakes by telling them their illness isn't real, just like we can risk serious harm by blindly accepting everything that a patient tells us and acquiescing to their requests for specific treatments that are not indicated. But what is true of all these patients, short of the pure malingerers, is that they are experiencing anxiety, fear, and other forms of emotional distress. Acknowledging that distress and treating them with respect and empathy is never going to be the wrong thing to do. Whether you, the viewer, is a medical professional, a patient with chronic illness, or just find this topic interesting, feel free to drop a comment below on your thoughts. But consistent with what I just said, please keep it respectful. I was originally going to also include here a discussion of the Illness Fakers subreddit and reactions to that subreddit from chronic illness communities, but this was already quite long enough without that digression. However, do let me know if you'd like to hear that about that adjacent topic in a future video.